Thank you so much for having me today. I'm delighted to be able to cross the ocean and talk with you all. And hopefully we've got a range of things that we're talking about that will be useful to you wherever you may be and whatever kind of work you may be doing. I'm afraid I'm a little bit of a fast talker and I have a lot of slides, but I'm hoping that you can take what you need and please feel free to reach out if there's more information that you'd like or a breakdown of something in particular. Here in Australia, we like to acknowledge the traditional custodians of the land. For me in Canberra, it's the Ngunnawal people, and this is a tradition that's been going on upwards of 60,000 years. That we lost the skill and tradition of doing for a couple of hundred years, but we're back in the habit, and we have a very beautiful location. You can see lots of wide open spaces. This is just up behind my house where I like to go walking, and it's a wonderful way to stay grounded and connected to the history of the places that we live and thrive. So I'm going to spend the next 15 minutes talking to you about dignity of risk, sharing and supporting decision making, and I might get some time to run through a few research examples that really exemplify how dignity of risk and supported decision making can work, and the work that we need to do to help, I guess, shift the workforce perspective around how we do this kind of decision making. I'm going to talk a few things about, I guess, context that probably many of you are well aware of. We have an ageing population. Our life expectancy has increased, which is a huge success, but it also compresses complexity at the end of life. Frailty, comorbidity, and disability are often used interchangeably for the older population. And sometimes there is unintentional tolerance of functional and cognitive decline in our healthcare system, and often a bit of an ageist system. We tend to have a labelling of geriatric syndromes and challenging behaviours and other nomenclature that really describes things that may be preventable or may be manageable in a different kind of environment as being problems or having a diagnostic component. There's often a few misconceptions in that, and particularly here in Australia, and this is Australian data, I apologise, but the majority of people who are over 65 are living in the community, and people with dementia, including that. I was working recently with some health scientists here, and their assumption was, when they were doing some dementia mapping, was that everybody who had dementia was living in a nursing home, and that's very much not the case. But older people are more complex. They've accumulated comorbidities throughout their lifespan. About 10% in hospital will have dementia, and about 50% in nursing homes will have dementia. There's about 30% with some kind of cognitive impairment, including, say, something like a delirium. And 90% need assistance when they're in hospital from one or more of their activities of daily living. That's why they're in hospital, and they are more complex. They're less likely to receive other kinds of care. But there's enormous variability, and this is that kind of misconception that older means more unwell. There's enormous variability in a fit old or the sick old. You know, some 90-year-olds can do crow pose, that yoga pose there, and others cannot. And having clinicians making sure that they're recognising and maximising what people's abilities are is really important. So there's a range of common cognitive impairments that I'm sure you're all familiar with, but these are perhaps the ones that particularly are impactful when we start talking about dignity of risk and shared decision making. And some of the kinds of care environments that we provide this care for, and I'm not completely familiar with what it looks like in Hong Kong, but I certainly know that in Malaysia that the trends between being able to provide at-home care and then the kind of hospitalised environments that have then trended towards older person care have created kind of institutional environments that aren't necessarily supportive of dignity of risk and shared decision making. We recently had a Royal Commission into aged care in Australia, and it was found a lot of appalling conditions, and that there was often separations from the community, there was stigmatisation, there was a lack of recognition of personal characteristics and values and perspectives, and that residents were likely to experience reduced quality of life and agitation and withdrawal, and the inflexibility of these environments was contributing to this experience of living and ageing. But there's a whole range of modifiable risk factors, both in preventing dementia and preventing delirium, and then also in ameliorating the complexity of the experience and the rapidity of the decline. There's a few listed here that, again, I'm sure you're fairly familiar with. And recently, the World Health Organization has released the rehabilitation packages and includes a range of different interventions for rehabilitating with dementia and rehabilitating from delirium. And this hasn't always been the kind of framework that people have been working from, and it continues to need to be socialised about accessing the right kinds of interventions for people instead of assuming that they have a geriatric syndrome and they are declining and on their way to dying. And so a big component of that is thinking about cognitive reserve and neuroplasticity. And so recognizing that at every age, including over 90, the brain continues to maintain its neuroplasticity and ability to learn and make new neural pathways. There's a lot of evidence demonstrating exercise, sunlight, sleep-wake rhythms, different kinds of cognitive engagement are really constructive in enabling these kinds of neuroplasticity. And obviously, the higher the level of cognitive reserve as somebody is aging, the more likely they can access that neuroplasticity. So if you're working with somebody who's 60, you're planning to get them to 90 and thinking about how else we can maximize their physical and physiological abilities to get there. And I just think this is a slide just always thinking that early treatment is prolonging that maintenance phase, prolonging that active rehabilitation, if you like, rather than allowing or presuming decline. And so dignity of risk comes into this space because sometimes that means about choosing activities or enabling activities in the population that we're caring for that perhaps previously were considered unsafe or were considered not within the primary focus of our clinical interventions. So dignity of risk is a term that's come from the disability sector and the mental health sector, where there's a recognition that dignity and choice are key to individuals maintaining their autonomy and a sense of self. And it's all right to take reasonable risks. It's all right to make decisions that aren't perhaps necessarily good for you. This is something that most of us have been doing all of our lives. And yet sometimes when those decisions get taken away from us, we start to have decisions made for us that maintain us into a bubble of safety that isn't necessarily fulfilling their sense of self or meaning, and therefore not enabling them to access some of those other things like exercise or sleep-wake cycles that they've actually practiced for the last 60 or more years. And so a lot of the work in the dignity of risk space is this balance between duty of care and dignity of risk, and providing supported decision-making for the people around you so that everybody's on the same page about what choices that individual is making. This is a picture or a meme that I use all the time. When I get old, they're never going to say, "What a sweet old lady." They're going to say, "What on earth is she up to now?" And sometimes that perception, and it might be your family member or somebody that you know really well, and the person that you know them to be doesn't look like the person that you then see in bed when they are unwell. And the nurses are not accustomed to what their previous kinds of choice and lifestyle were, and just then tend to make decisions based on that little old lady in the bed. But each of us has our own preferences, our own choices, our own tendencies towards different kinds of risks, and it is part of our human right to continue to make those choices. And those choices should be accessible to us no matter what our cognitive capacity is, and it might just vary depending on the level of cognitive capacity as to what kinds of decisions need more or less kinds of support. So somebody who may not have capacity to make financial decisions about purchasing a house can still decide whether they want to have a shower in the morning and who with. And sometimes this is what gets challenged in an aged care setting where we're accustomed to putting our requirements ahead of perhaps what the patient or resident may wish for. My two examples here is a lady who has dementia, early onset dementia. She has a key around her neck. She has no idea. She waved it at me. She said, "What's this for?" She didn't even know it was a key. But she is still able to ride her bike. She rides her bike all around the suburbs. She continues to go to a church. She finds new churches when that church closes. And her daughter accepts that the risk is high, that she is riding around on the roads, but she would prefer that risk to her rotting in a chair in a home, which was specifically the words the daughter used. Another example is there in the text about a lady who had dementia but was still able to catch buses, and the nursing home found ways of supporting her to do so. And so recognizing supported decision-making as being not black or white between autonomous decision-making and substitute decision-making, but there's a pathway in between, and that this graduated approach is often the work of nurses and others working closely with people with dementia or other kinds of cognitive impairment. The capability is realized independently or through a collaborative process of support from a group of people in the concerned person's life who knows them well. And it's about promoting, protecting and ensuring human rights for people with a disability. And just so that you know that the legal framework is there, the Convention on the Rights of Persons with Disabilities has been signed by almost all countries more than 10 years ago. And that legal capacity should not be defined based on cognitive disability, requires that all people with disability are before the law on an equal basis and are supported to exercise that legal capacity. And so these are the principles, and here I've got the Australian Law Reform Commission to support those interpretations, and that the preferences, rights of persons who may require decision-making support can direct the decisions that affect their own lives. And so there's a few different ways to interpret these risks. We can use a person-centred risk framework to try and get people onto the same page about the level of risk and not treating all risks as the same. And often when we think about people with dementia and we perhaps start mapping them onto the tiers, I'd be interested if this is something that you are familiar with, the behavioural and psychological symptoms of dementia tiers that Brodati and team made in relation to health services. And sometimes as behaviours get more extreme, then the decision-making capacity actually is restricted even further, when in fact perhaps these are the times when the behaviours of unmet need really need different kinds of responses to be able to decrease the impact on others and increase that sense of personhood for the individual and the psychological safety. And a lot of the work that we do in the BPSD space is related to these behaviours and trying to recognise what are the anxiety and stress thresholds that are perhaps restricting and creating behaviours, and what we might be able to do in a dignity of risk framework to decrease those stresses to therefore decrease behaviours. And so a big part of this is recognising the complexity of communication, including, well, particularly for people with a cognitive impairment. And so that meme that I used at the beginning with a nice picture and something that said, it's a conceptual thing, it's a symbolic communication. You could understand what I was saying based on the richness of that imagery, as well as that quotation. However, that's very intentional. There can still be intentional but informal communications. And say we've got Bob here and he's making this face. Unless you know Bob, you don't know whether he's saying rack off, or sorry, a bit of an Australian term there, or can you make me that cup of tea? It's 10 o'clock. And that might be the way that Bob always talks. And then there's unintentional communication, where the physical expressions and facial expressions that somebody is using is communicating something to you that you can interpret. And the better that you know Peter, then the more easily you'll be able to interpret that level of communication. And Watson describes how complicated this process is, and particularly we often have care workers, particularly sort of unskilled, untrained individuals who are working closely and doing the bathing and the showering and the hygiene and the dressing. And they're responding to these kinds of expressions. So the spitting is usually when he's distressed about something. I mean, he told us he was okay, but staying here with his humming. He didn't cry and teeth grind until he was hungry. So to me, he made a decision just by being here. And so that care worker interprets those preferences, that decision, that choice, based on expressions, but not necessarily articulations. And so this is, again, this map between the autonomous decision-making to the substitute decision-making, and recognising this is grey and that we can move back and forth across this continuum at different stages of different decisions and at different life courses. And using some of this language can be helpful about whose best interest are we looking at when we're balancing conflict? What are we looking at when how somebody might make decisions? Is it retrospective based on what we know of previous conversations about what that person wanted? Is it different kinds of cues? Do we need to provide fewer options to help that person choose? Is it just between catching the bus or staying home? Is there a way of simplifying what it is that they want? But again, generally our society expects self-determination to be dependent on individual communicative competence, and thus people with severe or profound intellectual disability or nonverbal dementia are excluded. This is changing, so that although communication may be primitive, and sometimes, it's the person who's fighting off having a shower, perhaps they're using swear words or different kinds of physical language to say, no, I don't want that shower. That is still a communication about not wanting that shower. What is it that we need to do to communicate differently? We need to acknowledge and notice these expressions of preference, interpret them, assign meaning, and act on the meaning in order to move towards supported decision-making, and arguably document that decision-making. And so there's a few different risk-taking consent forms that you might find useful in your practice. This is one I found from Ananda that helps identify and articulate between the different parties, between the staff members, between the family members, between the person with dementia if suitable, so that you can come to an agreement. And so with the tiny bit of time I've got left, we've got a range of, I guess, research examples. And I guess I took this opportunity to try and talk about the principles because each of these research projects have embedded this kind of project approach within them. But I think that we are missing it frequently in both our teaching for undergraduate nurses and clinicians and in the kind of socialization of it in clinical settings. So we have a few different examples: small-scale dementia care, a dance program, and a SPICE program, an early component, multi-component intervention for people with dementia. And then we've got a few programs where we're changing the workforce, where we're really incorporating these principles into the next generation of undergraduate nurses and new graduate or transition to practice nurses. So SPICE is a program where we take 6 dyads, so person with dementia and their carer, and they undergo cognitive stimulation therapy, care education, peer support, and exercise program together. And so all of these involve some kinds of risks. They've started up their own WhatsApp groups and they've learnt different things about risks that they can then socialise within their group, because otherwise people post-diagnosis of dementia don't tend to get a lot of support. This is a beautiful program looking at people with Parkinson's disease, and they were participating in performance. So they would actually go and perform on stage with their Parkinson's. And the article is actually called Out and Proud, because often for them, this was the first time that they'd acknowledged to the public, kind of announced that they had Parkinson's disease. And so this is incredibly powerful, again, risky in, I guess, a psychological sense, but really important. It had really kind of benefits to feel so normal from doing something that was different from what they otherwise would have done to retreat with the disease. This is a beautiful PhD student, Robin Lewis, who just presented yesterday for her confirmation, looking at small-scale dementia care. And this is really a way of embedding the dignity of risk framework, because it's in a home-like environment, to try and decrease that institutionalized focus and enable more choice and enable more normal living about making cups of tea and enabling them to cook their own food and do their own washing, which again has different kinds of risks, but is then part of a more normal lifestyle. This is the Gerontological Nursing Competencies Program, which we are using as a transition to practice program, and which has also been translated into Mandarin, not yet Cantonese. And this has been used, this is a quote from one of the reflective portfolios from the nurse, where they've identified the complexities between the 3 enduring powers of attorney. So these are kind of the guardians, the family guardians, who were appointed, and they all have different outlooks about what is best. So they're advocating that this is a demonstration of supported decision-making. That's just mentioning the validation of that tool. And this is a clinical placements for older people. So this is a piece of work where we're improving the experience of nursing students and by supporting clinical facilitators to have more gerontological nursing content. So we're upskilling the educators, if you like, to better support the students to be better gerontologically prepared. So my take-home messages are about minimising this black and white interpretations of capacity, consent and informed decision-making, and increase this focus of the rights of the older person. Recognise how individuals indicate their choices and exercise autonomy. Recognise the right to the dignity of risk, and consider advanced care planning early on. I hope that wasn't too fast, and hopefully that was useful to you all, and happy to take questions after the next speaker's had a chance to have a chat.